In real life.
All right, good morning. It is Tuesday, April 29th. This is Senate Health and Welfare. We're getting started a bit late, having gotten off the floor just a few minutes ago. We're going to hear from folks who are on our agenda to offer testimony. I'll look and see. So Mary Block is here. And Mary, I'm going to go to Nancy Payne first, and she's a distance away and remote, and we don't always have the luxury of having her here. So thank you for being available to us, Nancy. We greatly appreciate it. We're looking at H482, and trying to remember the specific question that we wanted to ask you.
Whether there was a better metric than days cash on hand they used.
Right. Oh, yes. So the question in the bill, determining a better metric than cash on hand for determining a solvency or
It's for fiscal health of the hospital.
yeah, period. Yeah, I go just leave it at that for now.
Sure. Do you want me to start?
I would like that very much.
Okay. So let me just preface this with a lot of this depends on how much time you have to measure the metric and what your time intervals are. So days cash on hand. So how do you get that balance is affected by how fast you meet your vendor payments, how quickly you collect your receivables, whether you've just borrowed a short-term note, whether you've paid down a lot of debt, whether you just bought a piece of equipment, a whole bunch of things. So at any one day, that cash number is, will change. And it's also very much affected by capital market behavior because it's valued at market value, not at historic cost. So my problem with days cash on hand as a measure of, financial health is they do, something like University of Vermont has a lot of cash and investments, but it's going to fluctuate like crazy, especially this year in all the volatility in the markets. So as a measure that you say you track, monthly, I think it's going to be really unreliable, and you're not going to be able to use it for the purpose which I think you have in mind, which is to be able to call on UVMMC or UVMHN, whichever thing you're looking at, to help out if Blue Cross is having a fiscal emergency. Because the day you look, it could just, your days cash could be 100. The unrestricted net asset is a little bit better in that it fluctuates with the effects of income, and it's a cumulative effect of income over many years. But it too is very vulnerable to capital markets because fluctuations in the market value of cash run right through your income statement. So I think what I'm trying to say is I'm not sure that the approach is going to give you what you think you need, and I think I have some thoughts on what else you might consider, because I think what you're going to say is, let's just run through half of a fiscal year and suddenly Blue Cross is in crisis and they need cash. That's kind of too late, and it would be better to say, well, how much is Blue Cross expecting to pay UVMMC given its rate, what's approved for its rates, and have it pay some, figure out how to pay UVMMC, say 85% of that and reserve 15% of it in case volume runs over expected. And then they have this withhold that they can then draw down on in terms of they just didn't pay it to UVMMC. It's cash sitting at the Blue Cross in reserve in the event that they hit budget. If they go over budget, that reserve goes back to Blue Cross. That way, you're not trying to get cash out of an organization. First of all, you got to figure out how to measure it. Secondly, you got to figure out how to transfer it. And by then, your Blue Cross plan's in jeopardy. So you might want to think more about something that has to do with the way it's paid. How Blue Cross pays University of Vermont or any other entity, such that there is a reserve or a withhold that says if we hit our expected budget and live within our premiums, you get this back. If we don't, we keep it. And that way there's no measuring at the health system or hospital level of any particular metric. And I would say that, you'd want to have, and that can be, the other thing about that is it's more certain. Right now we're in a horribly uncertain financial environment in healthcare, as you know. And so this is something that at least is the amount you get paid from Blue Cross is a certainty. It's below maybe what you'd like, but it's a certainty. As opposed to somebody saying, in February, oh, we need $100 million in cash. And that's an uncertainty, which drives credit markets crazy. So I'll stop now and see if you have questions.
Recommending is what the bill does, which is reduce reimbursement rates. I think the question is which hospitals become eligible to have their rates reduced. We're looking for sort of the most.
Do you want to ask that question?
Sure.
Please.
I'm Jen Kirby from the Office of Legislative Counsel. I think the bill as it's structured does what you're suggesting. It would give the board the ability to reduce Blue Cross rates to a particular hospital. I think the question is which hospitals become eligible to have their rates reduced. And it's the days cash on hand that's used, at least currently in the bill, to identify hospitals that might be and have sufficient financial strength to weather that rate reduction. And so is there a different way we could evaluate which hospitals are in the strongest financial position to be able to withstand a rate reduction mid-year?
So I understand what you want to do is say these guys are eligible and then can only draw it down so far before they're not eligible. And I'm just saying that's really hard to do on a fast basis and on a really meaningful basis. Unless you say, well, we're just going to look at what you did last year. And whatever you did last year is going to be the determinant of whether you're financially viable enough for us to do this. But what you won't be able to do is in a meaningful way say, well, now you're below that threshold, we're going to stop. So I can tell you right now, you can look at the balance sheet of UVM Medical Center and say, well, they've got $1.1 billion in net assets and, 800 million in cash and investments and 139 days cash on hand. And so they're eligible for a rate reduction. But in February of 2026, that may not be what they are. Whenever your crisis hits. I'm just trying to think of how do you actually use those numbers to implement. So you can go on a look back and say, these have been audited and here's the numbers. And we're going to take the, certain days cash on hand can be anything from one day to the next. So I would go more with unrestricted net assets above $1 billion. Because at least that cash isn't all debt. But again, these are numbers that are not immediately available the minute there's an emergency. For instance, the unrestricted net asset is a function of your income statement. And your income statement is a function of what do you think you're going to collect in revenues? How much is unrealized? How much of your investment market fluctuation is hitting your bottom line? What's your pension fund adjustment? And these adjustments are usually done not every day, but sometimes only at the end of the year. Days cash is just as crazy. All kinds of things hit that. Did you just repay a big chunk of your notes payable? Did you just buy a piece of equipment? Did you just collect your payables faster, collect your receivables slower? Those are all things that are going to affect cash. So does that help? I'm not sure. I'm just saying, I think it's going to be.
It definitely helps muddy the waters beautifully.
I know, I'm sorry.
Well, it would be extremely helpful to have your thoughts written down so we can look at them. Maybe if you could send us something in writing, that would be helpful. So what we're looking at, what we have looked at here during the past year is our largest insurance company becoming close to insolvent, and knowing that there's been some perhaps overpayment in our largest hospital, and how to transfer some of those funds to the insurance company to keep it solvent. And now, and at the same time, we don't want to start, if we have more than one hospital engaged in this process, we don't want to lose our hospitals.
Mhm.
So it's difficult. And you have just explained to us why it is difficult. So if you could send us that information, I don't know how much it's going to change the bill itself. I mean, one of the concerns we've heard is that to look at hospitals with 135 days cash on hand. How does that sort out? From your perspective, is that kind of a legitimate number? I mean, that was one of the questions that was asked last week. We're trying to get to understanding what is the best metric to use here.
Yeah, well, you did, I mean, there is, the word legitimate requires understanding what you mean. So one way to think about it is you'd want, the last 3 years average days cash on hand. Again, realizing that it fluctuates daily on a basis of other things, a lot of things. And that would make them eligible. But what worries me is this next step, which is if it can't go below whatever. Well, it goes up and down all the time, every day for different reasons, whether you're taking money out or not. So I can tell you, I mean, I can look at every hospital in Vermont and say, these guys, don't take anything away from them, you're going to tip them over. And then you can see.
We've got some of those. We have some.
You got those. I know you
5 of them at least.
You got a lot of them. There's
Yeah.
probably only 1 or 2 you could ever take anything out of. And it would be, the one that's got the $1.2 billion in cash, or actually, and remember too, that another thing about cash, UVMMC is part of a network, a system, and the system has half the cash.
Yes.
They keep it up at the parent. So,
Yeah.
what are you going to count?
Yes.
That's a discretionary, that's somewhat discretionary, how that gets back and forth. So if I were UMMC and I had to worry about somebody taking my money, I just put it all up at the parent and say, I don't have any.
Yes. Were there questions? Senator Dulick, Senator Douglas. Jen, did you want to ask another question? Nancy, thank you for being available to us. If you please send something in writing to Kiki that we can sort of look back on, and any thoughts you have about how you can balance out the ups and downs. We know that the financial situation now is one of radical change, mostly going down in the country. But if there's a way, your thoughts you have in an emergency situation, such as what is referenced in the bill, that would be helpful. And not destroying some of the smaller hospitals. I know that's been an issue. And how do you keep the money from being hidden somewhere? That's an issue. So there are a lot of pieces to this puzzle.
Okay,
Thank
I'll do what I can.
All right, thank you so much. Appreciate it.
Sure. Good luck.
And you can stick around if you would like, because we may get into more discussions. We're going to ask Mary Block, Department of Insurance, DFR, come up. You're the Director of Insurance Regulation.
I am indeed.
This is the first time you've been here.
I think it is.
All right, so we're going to introduce ourselves.
Okay.
And we'll start with Senator Douglas here.
I'm Senator Douglas, or 74 Orleans County Senate District.
Ginny Lyons, Chittenden Southeast.
Martina Rock, Dulick, Chittenden Central. And Cummings Finance. I'm Chair of Finance. You'll see more of me.
I've seen more of you. Yes.
Well, and Senator Hart is out for most of the week, so he's here in spirit.
Okay, so for the record, Mary Block from the Department of Financial Regulation. So in the interest of time, you have Commissioner Sampson's,
Yes,
Memo.
we have his memo.
so I can walk through it or I can just answer any questions you might have.
Why don't you give us the highlights of,
Okay.
what was in that, I have it here. It pretty much concurs with the, what the Green Mountain Care Board has said.
Yes, so obviously the Green Mountain Care Board's memo is a bit longer because there's some sections of the bill that apply solely to them and are not DFR issues, so we commented on those that we felt were connected to DFR. So one of the items that we commented on was the sunset provision, which suggested be March of 2026. We didn't feel that that was a long enough time period to have any progress made on the financial condition of Blue Cross Blue Shield at this point, and believe that potentially a farther out, maybe March of 2027 would be a more appropriate sunset. Another suggestion was related to changing the lower reimbursement rates to a lump sum or a loan. A loan is a non-starter from the perspective that it actually adversely affects capital. So have the opposite effect on your income statements and their RBC. And a lump sum, we don't feel addresses the issues. We feel like the decreased reimbursement will follow whatever is sort of happening with claims and so forth that are impacting RBC. And so it makes more sense for that to be the measure as opposed to a lump sum. Plus, we think that figuring out how to calculate a lump sum, it would be extremely difficult because you'd be trying to guess going forward what would be happening and how much you would need. There was a suggestion to change, so there's a trigger both to change the reimbursement, decrease the reimbursement, and then to stop, essentially to return the reimbursement level where it originally was. There was a suggestion to change the wording on that from meet to receive. RBC is calculated technically on an annual basis, and we would be looking at interim RBC essentially here. So meeting is an exact number, right? So we're talking about 200% level. There's space in between. And so the fact that we're dealing with an interim number and we're not, it's constantly a moving number, exceeds works, is more appropriate than meet. There was a suggestion to limit the reimbursement adjustments to put some type of cap on there. I feel like we agree with Green Mountain Care Board's comments that a cap is unnecessary because we have these guard rails in the statute in order to tell us when to turn off and turn on both based on Blue Cross Blue Shield's financials and the hospital's financials, and so a cap seems unnecessary. And then finally, there was a suggestion to change the statutory reference with respect to RBC. The reference that it was suggested to change to is actually the definition section and isn't the full section that was originally in the bill, which makes more sense from a statutory perspective.
Okay, thank you. So, and that reflects the memo that we received from,
Yes.
Kai Sampson. I do have a couple questions. So, it might be helpful just to, well, before that, when you look at solvency for, the insurance companies in particular now, we're very concerned about Blue Cross and Blue Shield, and we cannot afford to lose them, period. And so when you look at their solvency, you're looking only at their reserves. Do you look at other elements? I mean, and I think not just in the short term, but over the longer term, do you look at the contracts that for payment that the insurance companies have made with providers or with individual hospitals? So could you point to a specific hospital and say for their lower base care, their insurance reimbursement is X amount? Do you know how much insurance companies are paying to hospitals? So do you have a bead on kind of that balance of payment?
So. Complicated answer.
That's okay. Okay.
So we could, how's that? Financial regulation for insurance companies varies depending on whether it's a domestic insurance company or a non-domestic insurance company. Health Shield's a domestic insurance company. The way the system of regulation is set up, there's a primary financial insurance regulator, which is the state in which the company is domiciled. There is a much more extensive process undergone in that primary state than there is in, say, for example, for MVP, because MVP is New York domicile. But there's an entire system of regulation that's set up by the NAIC that all states adopt that is designed to allow us to rely on each state to rely on the primary regulator to know that they're looking at the same things that we're looking at. And there are detailed statutes, regulations, guidelines for how we do that, how RBC is calculated, what financial statements are supposed to look like, what income statements look like for the tests that we do when we do an examination versus doing just a financial analysis that we do on an annual basis. There are requirements that are done annually, which is those financial analysis requirements, and then there are comprehensive examinations, pure primary regulator, that are done every 5 years. So depending on who the insurer is, we do more or less, if we're their financial regulator, if we're not, or we're their market regulator and so forth. We look at, there's sort of a minimum baseline of what we look at. And then depending on what we see, we can go in any direction. We have the authority to look at those contracts. We have the authority to ask for bunches of claims information if we want to dig in and see what's happening. It just depends on what we're seeing. And then when things are not going well, based on those RBC triggers, there are certain suggested steps that we take based on various levels, and there are in some cases mandatory steps that we take depending on how bad things have gotten, and each of those action levels that are referenced in the bill. So it's a pretty comprehensive look depending on the circumstances.
So what I'm hearing you say, so I could make the assertion that then it would be very difficult for an insurance company to hide revenue anywhere. So
If we're the primary regulator, yes.
yes, for the primary regulator. And so as compared perhaps with a way of hiding things, I mean, hospitals could right now theoretically could hide with a network, hide funding and send it somewhere else.
Yes, so part of
the
those
regulation is slightly different.
part of those regulation is regulation at the company level and regulation at the holding company level. So there are actually a set of statutes that govern how we look at companies that are a part of a holding company network.
Got it.
So that gets avoided.
It's a very well and heavily.
Right, well, no, it's important. I think this committee understand that your committees had maybe more.
Lots for.
Yes, I know, and I was there, so I know there. But, okay, thank you.
Doing the housekeeping on the floor next week. You think transportation was long?
All right, any questions for Mary? So you are representing the position that Commissioner Sampson sent in. And when, as you look at Blue Cross and Blue Shield, what is your job with respect to the work that's currently going on?
Mine personally?
Yeah,
So I'm the director of insurance
you
regulation.
personally.
I'm the director of insurance regulation, so I sort of,
Make sure everybody's doing their job.
yeah, I do a little bit of everything. Right now I am also starting to fill in for Deputy Commissioner Brown as she makes her transition out. Friday is her last day. So for now, I am the backup plan.
We're going to miss her.
We are all going to
Yes,
miss
we're
her.
going to miss her a lot.
Oh, Yeah.
Okay. All right, questions? All right, we're good. Thank you so much. Appreciate your time. And if you, so we have the testimony that Commissioner, Sampson said, so
Yes.
there's no need to provide anything further. I think like, we can go back and read Title VI if we want, Title 16.
Title 8.
Title 8. Hold on. Okay. All right, committee, we've got 3 minutes, and so what I'm gonna suggest is we adjourn for the day. We're gonna come back to both 266 and 482 as quickly as we can, because we've got a lot to talk about in here. We have a letter, I asked Kiki to give you to print out information from VAS and from Fremont Care Board and from DFR. We're looking at that level. We also have information that we received from Blue Cross and Blue Shield. So take some time to look at that, look at the bill, and our healthcare advocates here. Okay, did you want to testify today? No, you've already had them. Okay, all right, so we are going to adjourn